Welcome to today's session, Managing Healthcare Operations, Integrating Indigenous Knowledge in Project Management. In this final session of our Managing Healthcare Operations Community of Learning, participants will learn information on weaving Indigenous transfer of knowledge, ITALK model, into foundational framework of native ways of knowing NWOK, traditional project management, and agile project management. Thank you for joining us, and let's get started. My name is Molly Connors. I'm a public health associate here at NCUI. Joining me from the NCUI team are Micah Grant-Honthropp, public health project coordinator, and Amy Lord, senior communications associate. We are honored to have you here today, and we kindly ask that you place your name, organization, tribal affiliation, and title into the chat box. Next slide, please. This event is made possible by Indian Health Services Corporation Cooperative Agreement Funds. It is the sole responsibility of the National Council of Urban Indian Health and does not necessarily represent the views of Indian Health Services or the Department of Health and Human Services. Next slide, please. For those of you that are unfamiliar with NCUI, here's a little bit of background. The National Council of Urban Indian Health advocates for the 41 urban Indian organizations contracting with the Indian Health Services under the Indian Health Care Improvement Act. NCUI strives to improve the health of the over 70% of American Indian Alaska Native populations that live in urban areas, supported by quality healthcare centers. Next slide, please. Before we proceed, please note that the session will be recorded for educational and quality improvement purposes. The recording will also be shared to make it accessible to those who may have missed today's session and want to revisit it for content later. And the video will be posted on our website, so you'll have to check for it there in a few days. Next slide, please. Bit of housekeeping. Please note your mics have been muted upon entry. We always encourage participation and engagement in today's session. We invite all of the participants to turn their camera on and post any questions and comments into the chat box. There will be an opportunity at the end of today's session for a question and answer. So next slide, please. As we continue our webinar, we encourage active participation and value questions and insights. To make the most of this interactive experience, here's how you can ask a question in Zoom. Just click on the chat icon, type in your question, hit enter, and send it to the group. And we have Micah on the chat box, so she'll be able to get to your question should you have any in a timely manner. Next slide, please. I am going to briefly read through today's session objectives before introducing our speaker and getting to the main content. We're going to be learning about how to effectively integrate native ways of knowing and project management within an urban Indian health organization to streamline and efficient design processes. We're going to be building organizational and project management skills to collaborate across healthcare departments on a variety of design projects. And lastly, we're going to be acquiring tools to support the development of facility infrastructure that includes design, implementation, and development of technology and construction products. So a lot of good stuff. With that, next slide, please. All right, speaker introduction. So today's speaker is Ty J. Show. He is a member of the Blackfeet tribe in Montana and is currently a project manager at Native Health Phoenix, where he manages and facilitates the multi-million-dollar design and construction projects, ensuring that facilities are compliant with safety standards and governing code requirements, evaluating programs for opportunities to improve efficiency, and develops plans to meet the demands of growing healthcare organizations. As a developed project manager, Ty has built methods to effectively analyze and implement streamlined processes that improve efficiency and reports findings to executive leadership and senior management team. He also has experience with conflict resolution, strategic planning, and strategic communication projects in the government solutions and land use natural resources sectors. He has 6 years experience in stakeholder engagement, project management, research and grant administration and evaluation, place-based and culturally relevant curriculum development, and industrial engineering. Ty's background includes work in tribal and underrepresented communities to increase and improve engagement and access to public services, education, and healthcare by design of equitable delivery methods. Tai holds a Bachelor's of Science of Industrial and Management Systems Engineering with emphasis in leadership from Montana State University. And my Lord, what haven't you done, I guess, Tai? So with that, I would like to send it over to our speaker to start today's presentation. And we're so glad you're here, and thank you all for also coming on the webinar, and Happy New Year, everyone.
Thank you everybody for coming. Oki ni sukuex, ni stu ni daniku, taisho ni dos skets, it's a big skapi pigani. So I introduced myself in my Blackfeet tribal language. It's always good to start any presentation honoring the ancestors and the place that you come from. And that's truly what this presentation is about, is going back to your roots, applying it to your jobs today, and finding a way to tailor your culture and different systems into your everyday work, your projects that you plan. I know in the urban Indian realm, we all work on projects. There's outreach, there's infrastructure. So definitely some adaptable framework that we'll be covering. So the title is an Indigenous framework for project design and project management in public health. So I always start with native ways of knowing, honoring the past in order to get to the future. So as I introduced myself, I'm part of the Blackfeet tribe, particularly the Skapipikani. So in the image you see in the lower left-hand corner in that logo is the band of the Blackfeet that I'm from. And together they have a confederacy. We have 4 different bands that make up that confederacy, and 3 of them are in Canada. The image you see, there's 4 directions, and the center of it is the fire, and everything goes out from there. You have your different logos that we've had on the teepees, caves, different things like that. We all speak the same language, and we've all used the same government structure. So together we are the Confederacy of the Blackfeet people, and within that confederacy, there's tribes and bands, and within those tribes and bands are different societies. So these societies were dedicated to different aspects, just like there's departments at an organization. You have HR. We had societies that had all the knowledge for, plant-based healing. We had our law enforcement society. And a lot of times you were either born into that because you had a family that had a long line of participating in law enforcement, or had a long line of plant knowledge and herbs, or you were captured. You had the knowledge, you gained the knowledge, you listened to your elders, and so you were captured by that society, and you had to learn their customs. Not all societies have the same customs. And these all go back hundreds and thousands of years of practicing these different customs, appreciating Mother Earth. And so that was kind of the central value of these societies. And once a year, these societies would come together, whether it's a Sundance or, as we say, Okan, and they would come together and they would transfer that knowledge, so that the overall tribe and the overall confederacy had a common understanding of plant knowledge, a common understanding of law enforcement, a common understanding of values that are common among all societies, all tribes within the confederacy. So it was really that transfer of that knowledge that made it so special. You were transferred the rights to name. It's not just, you're not born with the ability to name other Blackfeet tribal members. You have to be transferred that right. And it's an experience. You don't just get given a right. They don't sign a piece of paper and say you can now name. They teach you, you listen, so you experience what it means to have that ability to transfer that knowledge, transfer a name, So transfer is definitely a key word here with this framework. And so the Blackfoot Confederacy, like I said, the Blackfeet Reservation towards the middle of the screen is where I come from. And then you'll see three more up towards Calgary and Lethbridge, Alberta. So we've been separated by what we call the medicine line, the 49th parallel, the Canadian and American border. And we call it the medicine line because we had thought, our ancestors had thought, you know, that thing's really powerful. It's able to keep families away from each other. That's why we called it the medicine line. And today we exercise our rights to cross that border without a passport because we have treaties in place to trade with Canada. So definitely some geography there, a little bit of background of where I come from. And so how does that relate to project management today? How can we take what we know our tribe was, what we know our beliefs and values were, and the systems that we use to not only govern ourselves, but to transfer knowledge? How can we use that in project management? So when I was in college at Montana State, I worked on a grant with NASA in collaboration with Montana State University and Browning Public Schools. And Browning is the reservation school that I had grown up, you know, lived there my whole life, went to college in Montana, lived in Montana. And so I thought, you know, how can I teach these students at the middle school level about science? How can I engage them and include culture in that? And so it took a lot of development, a lot of thought in integrating societies. I had spoken to some elders who transferred knowledge to me on what a society is, what it means, and what it means to be a part of it. And so I wanted to try to create that type of system of learning for, you know, 7th, 8th, 6th grade students so that they can become engaged. You know, we all have the cookie cutter curriculum, but I wanted it to be special to them. I wanted it to be a part of their identity. You know, in college, I had a class where we were broken out into groups and an individual thought natives were running around at a certain point. But no, we were astronomers, we were scientists. And so I wanted to teach these kids from the community I come from how to advocate for themselves and how to advocate that we were scientists. And here's some lessons that I learned. So for example, in the lower left-hand corner, you'll see the Energy Society. And so I taught them an Indigenous science lesson about energy. We had built bow and arrows. We brought them out to a stream where some willows grow. And we tried some choke cherry, which was traditionally the wood that the Blackfeet used for their bow. And they seen the difference between a willow bow and a choke cherry bow. And then they learned that kinetic energy, you pull it back, you're putting potential in it, and then you let it go, it becomes kinetic, it goes. And so then the next week we had done a Western science, a modern, you know, version of energy. And they built their own rockets. And so you're putting same energy into a system and you release it and it goes and becomes kinetic energy. So they made those connections between today's science as it's taught and their traditional Indigenous science. And it taught the same lesson. So on the right hand, you'll see a diagram that has 3 different phases. The first phase being breaking these classes, traditional classes, out into 4 different societies. Phase 2 is learning these lessons like the energy, where you learn the bow and arrow and the rocket. And then phase 3 is going back to that same classroom and teaching each other. So each society transferred knowledge that they learned in their depicted teepee in this phase. You know, as all the green went to the green, all the red went to the red, and then they went back to their own classrooms and shared that knowledge. So transferring, you included everybody, and they were able to transfer and share their experience. So that's really where this framework came from. And so how do I adapt that to my current role as project manager at Native Health, where a lot of development, a lot of infrastructure, a lot of projects are going on. So what we did was we looked at phase 1. We broke out different departments, there's different levels of an organization. You have your C-suite, you have your directors, managers, and then staff after that, your coordinators, your techs, all of that. So at all levels of the organization, we included them in a design process. And so all levels of the organization were represented in the medical society or work group. And then every level of the organization was represented in the dental group. So when we broke them out, we were able to have a more holistic design. We had heard from it. We heard from the users. We heard from the medical assistants. We heard what they need. What would they like better in a building? We heard from the directors. What would they like? What have they observed? What are some issues that come up? And so we use that to design some expansion projects here in Phoenix and the Valley. So the way that thought process worked is, the mission and vision comes from the C-suite and the board of directors. What do they want? How are we going to meet the need? What needs assessments, what community needs assessments are out there that we can utilize to really create a vision to be responsive to the community? And then the senior management team was able to work with me to break people out into different work groups specific to their role. And the little arrow or the little tourney is showing how designs were reviewed. So the work groups themselves, the medical, dental, BHD, which is behavioral health, community health and wellness department, and the administration, we would talk about things. We would work with the architect, get it in the design, make recommendations. It would get reviewed by the senior management and then the C-suite, and they'd give us the green light or some suggestions of, how they would do it. And we'd go back. And so it was an iterative process where any design recommendation went through an extensive review process before becoming a part of the overall design. And so you just iterate until you have a final design. And so the infrastructure design process that was utilized is a 4-step design process with architects. And so in pre-design, you basically have an architect, you have a kickoff meeting, you identify what scope, what are we doing? How much square footage are we going to be developing? How quickly can we do this? So you develop your schedule. How much money do we have? So you develop a budget. And then engaging stakeholders, whether it's the community or looking at the needs assessment. What would they like to see? What expanded services can we provide? And what's feasible? And then step 2 is schematic design. And in that phase of the project, you're developing space layouts. What needs to be next to each other? Medical services, whether it's optometry, which are your eyes, podiatry, your feet, your medical, your primary care, what needs to be close, what needs to be adjacent to each other. And then you get some conceptual drawings from your architect. You're doing some more research of what needs to go where. And then some sustainability strategies. You're looking at how to sustain this building for a long time and also expand. So leaving a little bit of room and growth or extra exam rooms so that if the patient base grows, you can meet that demand. So you're looking towards the future as well. And step 3 is the design development. And that is where you are getting your more detailed drawings. You went through the iterative process several times. And you know where things are. Maybe you're making a few tweaks here and there on a wall. I'd like the door here. So as you're moving along in this process, things become more detailed. You're selecting equipment that goes in there. How much voltage or amperage does a room need? Is it a lab? Are they going to have plenty of equipment that needs to be plugged in there? And so you make sure that it's sufficient electrically. And then you update your cost estimates again and reevaluate of what's feasible. And so the last stage of the design process is construction documents. And in these construction documents, they're your final set of drawings. So it's like you get instructions for a construction contractor or general contractor to be able to complete that project, build. Where does the wall go? What's the measurements? What's the thickness? What materials do you use? So everything becomes way more detailed when you get to construction documents, your final specifications of how to carry out that work, your furnishings, your furniture, what's it going to look like, what flooring, in what areas is that going to exist? And you ultimately end up with your final design, and you do some risk analysis. What can impact this project? So that's the design process that we use for any infrastructure or construction projects. And so specifically to Native Health, I'm going to talk about two different projects. And one, we used a framework that I developed, like I shared, with the lessons and the societies and the work groups, and one that we didn't. We had a small group of individuals and leadership that were designing a building. So at Native Health Mesa, it's the East Valley here in Phoenix, we were adding dental, optometry, pharmacy, and podiatry. And we already had behavioral health and primary care services there. So this is an expansion project. And the lower left, you can see we didn't use work groups to develop the design. It's still a pretty good design. I really like it. It's coming together really well. And on the right, you can see the floor plan for that area with pharmacy at the top, podiatry on the left, optometry on the right, and dental at the bottom. So that took a lot of that iterative process of the design in order to design this building. And then Native Health West, we call it NHW Community Health Center, and that's on the west portion of Central Phoenix. And we use the work groups. I had thought, this project's going to be big because we are moving our medical, we're moving our behavioral health, we're adding community health and wellness, we're adding optometry, pharmacy, and podiatry, and we're moving along with dental. So we had medical, behavioral health, and dental already. So we were expanding services. So definitely a lot of different design needs. It's a huge project. I thought, this is the time to implement a framework where we can truly transfer knowledge across the organization and across all levels of the organization. So this design is the result of almost every level of the organization and every department within the organization. So we ended up with a more robust design by breaking people out into work groups, working with the architect, making sure their needs are met, working through the iterative process. And so connecting the framework to the design, where you have your pre-design. So phase one is pre-design. That's where we broke everyone out into who's going to be in what work group. And then schematic design is where we broke them out into their groups. And we gave the architect some general information of, medical needs at least 2 exam rooms for every provider. And we'd like it designed for 6 providers. So that means 12 exam rooms. And in this block layout at the bottom with all the colors, we reviewed the design of the architect. And in each work group, medical, dental, behavioral health, community health and wellness, we reviewed the design and went back to the architect and said, all right, here's our feedback. And then they iterate again and they provide us the design development. And this is where now we have less feedback because we know where things are going to go. We know what's adjacent to each other. Now we would like to add, maybe a little larger conference room. We'd like to fit maybe 10 more people. We'd also like, maybe 1 more office in the primary care. And then we had received a community health and wellness grant. So we added additional offices for community health and wellness. So that you're still tweaking it at this point, but it's iterating, as you could see in phase 2 and phase 3, that you're iterating using these work groups. They're transferring knowledge, not just to me or each other, but to the architect who's actually going to be doing the drawings. And then phase 4, you have your construction documents, as I had shared the design process. So we had our final set of drawings. We finally have a full design. We have as many exam rooms as we need. We have as many offices as we need. We know what flooring is going where. We know what equipment's going to go in that room. And so we had a more robust, holistic design because because all levels of the organization were present in these meetings, because every department had a say, because we included everybody in this design, it resulted in a very robust design. And so a little bit of analysis on how I was able to evaluate one project against the other. So the first being earned value reporting. We have on the left side, we have project one, which was the Mesa project, where it was a very select group working on the project. In phase two, or project two on the right, you had the project that was integrative and collaborative, and we included everybody. We made sure everybody's voice was heard. And then you look at the time spent, how many days were spent for each phase of the design process. And you can see as we got to construction documents and permitting, we were way off the planned value. And by planned value, I mean, in the beginning of a project, you think something should take 12 months and it breaks out into phases. And so we were way over budget in terms of days on project one. So you want those lines to be close together because you had guessed it right, or you estimated it right. Versus project two, those lines are all very close together. So what we estimated it to take in terms of days to design the project, we weren't far off. And really the only one that took a little longer was permitting, which isn't necessarily design. So you had your pre-design, schematic design, design development, construction documents. Those are primarily your design phases of a project. And we did significantly better at the project two. And so what does that look like? We were 130 days over budget on construction documents because we would go back to the drawing board with our select group of individuals. And then the next week, somebody else would think of something and we'd have to integrate that. So we went way over the allocated amount of days to get the design done. And on the right, you can see that same phase construction documents. We were only 5 days over budget on that because we streamlined, we transferred the knowledge. We knew what we needed because we included people. And, you know, there was subject matter expertise that existed within each of those work groups. You had your medical directors, you had your medical assistants, and everybody contributed something to the overall design. So it really streamlined the design process by integrating some traditional knowledge. And so for overall, through permitting, we were 321 days over budget on project one, where we didn't have the work groups, where we didn't necessarily include everybody in the organization. And we were only 32 days over budget on a project that was larger in scope, but we included everybody and we ended up with a better design. So moving forward, how can we utilize a framework like this for other items? How do we operationalize a site once it's done? So looking at all levels of the organization, and then creating a work group that includes everybody that you see in the red, the C-suite, SMT, and some leadership from each department. Creating a work group that specifically responds to the operational planning of once the building's finished, how's it going to work? How are we going to make that move? And what all needs to be done? In community health centers, you know, there's different governing bodies and requirements on how to move a vaccine refrigerator. You need logs. You need to be able to operationalize it. So a lot of those high-level discussions are now occurring at Native Health via a work group where there's different levels of the organization and departments represented to plan that out. And what's that going to result in? A more holistic and streamlined move. So once we make that move from one site to another, we had already planned everything out. The subject matter expertise was in the work group. We transferred that knowledge to each other. We made a plan. We're working on a plan. We're finalizing it. And that results in a more robust plan. So a little bit less expected issues to pop up versus everybody just siloed out, working on their own, trying to make it happen. And then when we make the move, maybe they forgot something. And so that might delay patient care. So this really was geared towards creating less gaps in patient care. We want to be able to provide that patient care without having to shut down, or maybe we don't have licensure yet. So everything's been planned via this work group. And we iterate through until we have a more robust design. We talk to our C-suite, our senior managers, and we end up with a better plan. And so that's the bulk of my presentation. I hope you all enjoyed it. I am very proud to come from the Blackfeet Nation. I'm proud of the systems that I have inherited. And I try my best to bring those same systems to my everyday life. You know, they say you'll never work a day in your life if you do something you love. Well, I love who I am. I love being a Blackfeet tribal member. It's a part of my identity, and I try everything I can to honor my ancestors and still be true and integrate my culture where I can. And I'll turn it back over to Nakui. Molly, do you want to take it from here?
I would like to thank our presenter today for their wonderful presentation. Ty, you did great. And at this time, I want to open it up for a question and answer. So if you have any questions, please come off mute or drop your questions into the chat box. You definitely got me thinking on a few questions myself. So I think I'm going to kick us off. But please don't be shy and drop your questions into the chat box or come off mute at any time. But you're working with so many people. I'm thinking about logistics, Ty, and everyone that you have to include in the organization. You know, you have your C-suite, you have all of these meetings, and especially somebody working directly with patient care, their day is already so busy. How are you including them? How are you logistically having them have that voice at the table?
So it took a lot of coordination with managers to ensure that we were able to include, say, like a medical assistant, because they're direct patient care. If we pull them from direct patient care to a design meeting, are we really providing the level of patient care we need to? So it was like a logistical challenge, but it wasn't a barrier. It was a way that, you know, maybe there was a no-show one day, and we all know within community health centers that we never have 100% of our patients show up. So it was taking advantage of the windows that we could. Who's available right now? Calling the manager, emailing the manager. Who is available right now that's a medical assistant that can hop on a 30-minute design meeting and give some input and review? Sending out emails of design, explaining, giving them the opportunity to maybe redline it, give us bulleted suggestions. So sometimes it wasn't necessarily being a participant in the meeting itself, but they still had a voice because they were included in emails. They had a level of input. So it was a challenge to work with staff at the direct patient care level. But it wasn't a barrier. We made sure that they had a say at some point.
I love how you phrase that. Not a challenge, just a barrier. And I think you guys definitely overcame all of the obstacles and just made that shine. We have another question coming in from the chat. What is the best way to incorporate unanticipated changes or developments into your model? That's a great question.
So because the design of this framework is iterative, any challenge that comes along, you can see that this little circle is indicating that it's iterative. So if a challenge comes up, you're going to go back to the drawing board with your groups, present the challenge to them. They're going to brainstorm solutions, and then they're going to finally make their final design recommendation or how to pivot or how to adjust to this challenge that has come up and or change and say maybe we have less money to develop pharmacy. So what can we do to maybe make the space smaller? Maybe we don't incorporate it fully, but we need everybody's input. We need all levels of the organization to help with that solution. So you're going to iterate through this process where you're getting back to the drawing board with the groups, you're presenting the same problem to all of them, or all levels of the organization, or the overall work group that's working on it. And you're going to make suggestions to the senior management team and the C-suite, and then they're going to give their feedback, and you're going to iterate through that until a solution is decided on. So definitely an iterative process is what makes this more agile. It makes it more adaptable and responsive to any changes in design along the way.
I actually had the same question in my head with the first question as soon as you were talking, Ty. But what are some project platforms that you use to support both Western and Indigenous thinkers? So what are you using? What's your preferred platform?
So I look at, obviously there's your traditional Microsoft project. It's very technical, very data driven, how many days, what resources. But there's, even simple ones within Microsoft Teams. If you create a team, there's one app that you can add that you can track tasks and move it along like a process, like sticky notes. If you had a whiteboard, I'm not against sticky notes either. Not everything has to be virtual, but there are softwares that will make that like a computer version of a sticky note and whiteboard. So that's kind of like your agile methodology, where you have in your first column tasks that need to be done. In your second column, the progress. Have I started it? And then you have a third one of, maybe a quality check and then finished in your last column. So there are tools that exist even within Microsoft Teams that you can have a more visual experience. And I think tracking that is definitely kind of Indigenous thinking because we know it needs to be done. We know how to transfer knowledge. And Teams, we know, is a way to transfer knowledge to each other. So you're using visual aids, virtual sticky notes or virtual task indicators and moving them along in a process. So anybody on that team can look at that platform and know, okay, well, we have a lot of tasks this week and not a lot of them are done. What do we need to do? Let's maybe schedule a meeting. Let's get in our work groups. Let's hammer out some of these tasks that need to be done. So definitely some Microsoft Teams, Microsoft Project, there's Asana. There's definitely some software out there. But definitely reach out to me if you want to brainstorm any that might meet your needs specifically.
You've got me thinking now too. To anyone that's a software engineer, if you want to do an Indigenous project platform, just saying there is need. If you also know of an Indigenous project platform, please drop it in the chat because would definitely want to look into that myself. But that was a great question. Keep dropping it in the chat, or you guys are welcome to come off mute, and definitely appreciate your time, Ty, answering all of these. I had another question regarding, project work. Can you adapt this framework that you're using, building and constructing, a new facility to event planning or other options?
Yes, I'd say it's definitely highly adaptable. This framework came from curriculum development and teaching students 6th through 8th grade. How can I get these students to teach each other? How can we transfer knowledge from, say, me as an instructor to the kids in the society? And how can they transfer that knowledge to each other in the end? And I adapted that model that I developed into a model of project management and infrastructure. And so for event planning, say like a large foundation or a donation or a gala that is a major fundraiser for your community health center, you can adapt this by including different areas of volunteers. You know how you have committees. you have committees, but really what makes this so different than just a department at an organization or a committee, a planning committee, is that the goal was to include all levels of the organization. It was including so diversifying these work groups really led to a better solution, better planning, because we listened to we didn't just listen to the bosses. We listened to everybody. And that's what resulted in such a robust design, was because everybody's thought process was represented and we talked it out, and we transferred that knowledge. Not everybody holds the same knowledge. And so that's why I like to call this design the transfer of knowledge, because you truly are working in a collaborative environment. It's not just siloed out. And in the end, you're coming back together and you're making sure the overall event plan, the overall design for a building, or the overall curriculum that you taught sixth or eighth graders, is a more holistic version of what can be done.
That's a great answer. I didn't realize it was sixth through eighth grade. I mean, I did at the beginning when, you mentioned the rockets. I didn't think that you're going to have physicians. Not that that's not a great idea, shooting off rockets. Um, but yeah, it's a great way to think about it. Um, and everyone keep dropping questions in the chat or come off mute. Would love to have them. But yeah, I have another question while you guys think on more questions for Ty. How can community health centers and accreditation and meet accreditation and building requirements compared to FQHCs and IHS? So I know Phoenix area, you have different requirements than say, somewhere in California or even Montana. But everybody's got something different. But how are you guys meeting those requirements?
Okay, so it's really identifying what governing bodies are going to determine, how to design a building. So, with your IHS, you have the Joint Commission and JCO, that will dictate, if you need a door or you need a separate soiled and stale room. And then there's a different accreditations for us here in Phoenix. We have triple AHC, and their requirements are not the same as IHS. And then you mentioned like geographical, like it's different than Montana, it's different than Phoenix in California. Well, those are the codes that come from the governing authority, whether it's the city of Phoenix, the city of Mesa. So you're trying to meet those building codes. And so you're working with the architect and you're letting them know your needs, and they're experts in the code of the area. So they're able to look at the different codes that govern a building, and they're able to adapt your design to meet that need, whether it's adding a column, working with engineers to add a column for support within a building. But definitely being knowledgeable of what governing authorities are deciding how, or helping decide how to design a building. For example, like I mentioned, soiled and stale room. IHS requires them to be completely separate rooms, whereas our accreditation doesn't require that. But we still designed for the more stringent requirement, so that if our requirement changes in the future, well, it's already designed into a more robust requirement. So paying attention to that, what's feasible, looking at your budget, can we design for that more stringent requirement or code? And then making that decision, iterating through that work group and making those decisions as a team.
I love that. Yeah, definitely designing for not necessarily today, but what is tomorrow as well, just having that extra preparedness to be ready, not just for IHS's requirements, but also your local, exceeding the needs. So really great answers. I'm going to open it up again to anyone in the audience. If you have a question for Ty, please come off mute or drop your question into the chat box. I can't believe it's already, 45 minutes into this presentation. Time is flying by so fast. So I'll give it another few seconds here. for you guys to type away if you have anything. We will be sharing this presentation and the recording of the presentation, within the next few days on our NCUE website. So no worries if you came in late or needed to hop in and out. All right, I think I'm gonna go into the next slide. All right, we genuinely appreciate that you guys, your time and effort today to help us share future events. If you could scan the QR code or, the link that's being shared in the chat box, it takes you to a brief survey. If you've loved everything Ty was saying and you're like, I want to listen to more events like this, we'd love to hear back from you. And yeah, I love that comment from Allison, looking at potential problems before they become problems. Exactly. Future variables, thinking ahead. Great insight. All right, so please take a look at that survey and fill it out. Like I said, if you're about today's webinar and you want to see more of it, we'd like to hear it. So I appreciate your time on that. And then if we could go into the next slide, please. Awesome. So NCUE is committed to supporting our urban Indian organizations and the important work and services they provide every day for individualized technical assistance in everything from agency regulations to UIO billing and coding. Please fill out the technical assistance form. That's all form link found on our website and also being provided into the chat box now. So we are revamping our TA. We are providing more of it and more of it every year, it seems. So even if you're like, I'm feeling overwhelmed, looking through all these documents, can somebody make sense of this? We have a team for that. So hit up NCUE. We'd love to help and assist you and provide technical assistance. That's what we're here for. So next slide, please. Some upcoming events. Also, we're going to be putting that into the chat box. Register and join us for upcoming events in the chat box. The links for all of these can be found on the NCUE website. And we are placing a previous link to NCUE's AMA Ed Hub where CEU accreditation can be found at any time. This event is not for CEUs, but we have past events, so please check that out. And make sure to register and save the date for NCUE's annual conference, April 22nd to the 25th in Washington, D.C. Registration is now open, as well as call for proposals. That ends on, I believe, the 28th. So if you have a really great topic and you're thinking, I would love an opportunity to present this somewhere, consider NCUE, but consider NCUE soon. Because we're going to be closing that date, but registration will remain open. So send all your friends. It's going to be an amazing time, and also cherry blossoms. So really great to see those. Make photos even prettier while you're at conference. Next slide, please. And that's it. Thank you all again for joining us today. We look forward to seeing you at the next event. Which will be, I believe, at the end of the month. We're going to be having a policy preview for 2025. So you have a wonderful day, and please fill out the survey. And thank you, Ty, our amazing speaker. Great presentation. Wonderful having you. Thank you, everyone.